So the first thing is welcome everyone. It's great to see so many people here and some familiar faces in the crowd as well. I'm interested in finding out a little bit more about perimenopause and menopause. I'm Dr. Kirsty Short and I'm one of the founding members of Ali Healthcare, and that's along with Dr. Dominique Favell and also Dr. Julia Spicer here with us tonight. And you'll hear a little bit more from them later. I'm also a practicing emergency physician, and so my contact with women in healthcare is really at the pointy end of things. So women presenting in crisis in terms of heavy vaginal bleeding, severe pelvic pain. And I know that I will have misinterpreted perimenopausal symptoms as being attributed to something else in the past. I'm guilty of that, but hopefully things are going to change, and as we educate more and more clinicians themselves. I've also noticed with women's healthcare that it can be really quite fragmented, and that manifests itself as women seeking multiple consultations for the same constellation of symptoms or the same diagnosis because they just not feel they're getting anywhere. They're not necessarily happy with the information they're getting, and they feel that they deserve better. And so at Ali Healthcare, we really understand the need for that therapeutic relationship requiring time. And that's time with a practitioner that's qualified in women's healthcare, that's got an interest and experience and keeps up to date with evidence-based practice. That's time to ask questions and to have things explained in a digestible way that you can take forward with you. And time to have that, make that management plan and really individualized management plan that's reflective of your needs and, and local and guidelines and evidence-based practice. It's also important to be able to see what the response to those sort of management plans is. And so bringing it back to review of the patient and centralizing care. I think what we really need to do is break down these barriers, help to streamline the care and your experience of sort of your as a woman with all the healthcare challenges there are. And we want to be here to support you, be the best woman, wife, partner, mum, whatever role you have. And we have many roles as women, and really be the best person that you can be every day that you show up. Because today is all about perimenopause and menopause, and we've been speaking to many women over the last 6-12 months and certainly hearing lots of different stories, we thought we'd start by using a hypothetical patient that sort of encapsulates a lot of the recurrent challenges that we're hearing about. And we'll call that patient Ali for the purposes of today. So Ali is in her mid-40s, say she's 44. She's got 3 children, one of whom is school-aged. She's a professional, and she would describe herself as being happy, positive. She enjoys motherhood, and she considers herself a good friend, and she really prides herself in that. Now, things have changed over the last 6 months. Primarily, she really feels a lack of joy in the things that used to bring her joy, and profound exhaustion, similar to that in the first trimester of pregnancy. And she just can't shake it off. Okay, this is the difference. And so she used to get a buzz from going to yoga, going for a walk, getting creative in the kitchen, and she no longer feels a drive for that. And she can't place that feeling because it's so alien to her. She's never had any background of mental health problems, so she doesn't actually know what to do with this actually overwhelming feeling of sadness. She also has a sense of sort of doom that she's never felt before. So she's worried about everything. She's worried about forgetting something. She's worried about making a mistake, whether that be at work or in the home. And it's actually created quite a panicked situation that she finds herself in, to the point where she doesn't even want to answer her phone. Okay? She's concerned that what could be at the end of that? Could it actually signify that one of her worries is actually coming to fruition? And so this is a very distressing symptom for her. She withdraws from friendships, family, withdraws even from the relationships that she has that are key in the workplace. She also realizes that she's certainly not getting any of the sleep that she thought she would do, given that her children are now sleeping through the night. So she's finding herself awake at 3 o'clock, 4 o'clock, 5 o'clock, alone with her thoughts, not sleeping, unable to get back to sleep. And it just seems so unfair. And this is just feeding into the cycle of exhaustion that she's experiencing. She's always known what irritability could be like, particularly around her period. She's always had PMS, but tends to sort of get better on the first day of her period. However, the irritability she's been experiencing is vastly different from that. It's lasting the whole of the cycle, and it doesn't dissipate. Okay, and it's a lot severer than it has been in the past. She's fighting with her husband. The resolution of any arguments is taking a lot longer, and she knows that she's being short with her children, and she can see it. In addition to that, she's also noticing that breast tenderness is continuing throughout the entire cycle. Things are difficult to wear. She doesn't want to be touched. Her hair's changed in consistency. It's brittle. It's breaking. And to top it off, she's developed a beautiful moustache to go with it all, okay? So none of this is feeling like herself. She feels that her body is alien to her and her mind is alien to her as well, and realizes that she actually needs to get professional help. So her starting point is off to see her GP, and she's had a wonderful relationship with her GP over the years, particularly during the birth of her children. So her GP listens and organises some appropriate tests to see if there's anything else underlying that could lead to this. She gets her iron checked, thyroid function, calcium, vitamin D, and is then sent away for a couple of weeks waiting for the results. Now, over this time period, Ali isn't finding that the symptoms are resolving at all, and in fact really finding them quite distressing, becoming really tearful intermittently, and in fact when she revisits the GP she's feeling particularly tearful and starts crying. The GP is obviously very concerned and decides to do a screen for anxiety and depression, starts a mental health plan, and in addition to this suggests going to see a psychologist. Now, Ali's very pragmatic and she wants to get better, attends all 5 appointments with the psychologist, and certainly learns some great coping strategies in terms of dealing with the anxiety symptoms, and they help a little bit, but she feels that the root cause still has not been addressed. In the meantime, she's getting a lot of noise on social media, whether or not it's because they know she's of a certain age, and she hears a lot of things about perimenopause, menopause symptoms, and also there's a High Commission, Royal Commission going on about perimenopause, and so that interests her. She does a bit more of a deep dive and thinks that some of these symptoms really could be related to her. So on the 3rd appointment with the GP, she decides to bring this up. And the GP certainly listens, but there's a level of scepticism related to her, first of all, being young, being only 44, and a sense that the GP hasn't necessarily treated that cohort of young patients with hormone replacement therapy in the past. And so there's a really very abridged discussion about hormone treatment, and she's actually, instead of going any further with that, she's actually offered antidepressants and 2 weeks off work with the support of a sick note. Obviously, this really doesn't fulfill Ali's requirements, and she decides to find herself a GP with specialist interest in menopause because she's heard some are about, and is able to get in for an appointment in 2 weeks' time. Now, this is about 8 months down the line of all of these symptoms, and she's absolutely at the end of her tether. So she walks in and starts to have a conversation, and within about 5 minutes, the GP stops and says, "So how long have you been having these perimenopause symptoms?" And honestly, Ali is absolutely floored. She is heard for the first time in this awful experience that she's going through. She feels validated, and that she's not just going completely insane, which is what she's been feeling like. There possibly is something underlying this. So they have a really open conversation about the possible benefits to her symptoms of hormone replacement, and she starts on some estrogen gel and progesterone. Within 2 weeks, she feels significantly lighter. She's certainly not jumping out of bed each morning, but each day feels easier. And there's hope. There's this hope again that she really didn't think she'd ever get back. So on that note, I'm going to hand over to Dominique, who will hopefully continue some of this discussion and bring up some of the points that I've made with the panel.
I'm Dr. Dominique Favell. I'm the founder of Ali Health, and wow, listening to Kirsty, it's hard not to feel a little bit emotional. I'm sure everyone in the room or women in general can relate in some way to the experiences that Kirsty spoke about, then seeking health care for some other reason and not feeling like they've been completely understood, taken seriously or supported when they needed to be. And unfortunately, it's not uncommon. I think there was a 2023 survey done by the Department of Health that found 2 in 3 Australian women report feeling dismissed, not believed, ignored when they sought healthcare for various reasons. And that really is the reason we've decided that we can reimagine the way healthcare is delivered through Ali Health, with the idea that women should be able to access knowledgeable, empathetic doctors who understand the nuances of women's health, no matter where they live or what other barriers to care they might face. But we do also recognise that accessing clinical care is only just one piece of the puzzle. So we also offer wraparound support in the way of educational materials and tailored symptom management that patients can access in their own time. So Ali deals with women in all stages for many different things, but tonight is about perimenopause and menopause. So I'm really excited to have these lovely ladies to the left of me who have extensive experience in dealing with women in this stage of life and can bring a lot of valuable information to the front. I do want to say though, if you take away anything from tonight, it's that there's not one size fits all when it comes to perimenopause and menopause. Tonight is really about giving you the information to empower yourself, the language, the insights and the confidence to have conversations with your own health professionals or seeking a second opinion if you need to do that. So nothing is direct medical advice and shouldn't be taken as such. But with that, I'm going to introduce the panel. So Dr. Julia Spicer, she is a women's health GP. She has over 17 years of experience, of clinical experience, additional training in mental health, family planning, sexual health, and obstetrics and gynecology, and just, all around knows her stuff in this space. But more than that, she is empathetic. And as a patient of Julia's myself, I can say she's empathetic, she's patient, and she's practical, everything you need in a GP, and also a colleague. So I'm really grateful that she has taken the leap to be with Ali Health. Then we have Alex Turner. Alex is a women's health physiotherapist who focuses on pelvic floor health, particularly pelvic floor dysfunction and pain management. And she's also leading the charge on our pelvic floor modules and management plans at Ali. So thank you, Alex. Then we've got Gemma. Gemma's a trusted Ali Health collaborator. She's an exercise physiologist who has a special interest in keeping women of all ages as healthy as they can through exercise and movement. And then lastly, Shivaun Conn. Shivaun wears many hats. She's an accredited dietitian and nutritionist, but she's also an executive health coach, and also runs courses teaching other health professionals how to become a health coach. So your perspective is going to be really valuable tonight, I think. So with that, we might kick things off. We might start. So I've told everyone's qualifications, but maybe we'll listen to you guys about what that actually means and how you work with women in this stage of life. And I might start with Shivaun, because health coach is probably the less known.
Initially, I was trained as, can you hear me? Yeah, as a dietitian and nutritionist at university. And pretty early on in my career, I realised that it wasn't just enough to give people information and advice around nutrition. There's a lot out there, and it actually can be really confusing as well. And it's not the only piece of the puzzle when it comes to creating sustainable change. So essentially what health coaches do is we help people create sustainable change that lasts. So what happens is a lot of people come in with really kind of messy head, like I've heard this, I've heard that, I've been to these many health practitioners, I don't know what's going on. And as a health coach, we allow people to unravel that messy head, get all the pieces of the puzzle out, and help them to create a plan. So, okay, this is what's going on. This is what you're thinking. This is what you've heard. What do you want? What's your best self look like? What are you feeling, thinking, doing? What's already working in your life? What's not working, which we would have probably heard at the beginning whenever all the messy head comes out. We look at what's working and we go, okay, great. We summarise that and say, all right, well, you're drinking lots of water. You're doing your yoga once a week. You're doing this and that. And so we're affirming the changes, which is really important, so people's hope and confidence goes up there. And then we go, all right, with this bundle over here, you talked about work that's really flat out at the moment. You talked about the fact you need to be doing those strengthening exercises, but you just don't have the time. You talked about how you're trying to cook 3 different meals for family members and the hubby that's fussy. And you also talked about the fact you can't sleep properly at the moment. So out of those areas, what feels like the easiest to get started with? And what also feels like it's going to make the most difference. So we help people to prioritise, and then they go, oh, you know what, it's sleep, or it's the food. And we go, okay. So if it's the food, obviously I've got expertise in nutrition, so I can interweave that information there. If it's the other areas, what we do is we find out if there actually are informational skill gaps there. Maybe it's a referral to a psychologist or a physio or whatnot. Or can we harness the wisdom from the client so they come up with their own knowledge and their own strategies and steps. And then we create a little bit of a small goal with some steps to achieve it. And then as a health coach, we check back in. So it might be every week or every fortnight. So gradually we're building up that hope, that confidence, and women are step by step working towards that optimal version of themselves.
My name's Gemma, so I'm an exercise physiologist and with a special interest in the women's health space. My job, I feel, as an exercise physiologist is to create a safe space for women to learn how to move safely and properly. So there's a huge exercise education component from my side to speak to women about the different modalities of exercise and also talk through some of the confusion out there around strength training, cardio training, flexibility training, and sort of also create a plan that's individualised to the person that's in front of me. I think the first thing that I do is to listen to any signs and symptoms that come up in sort of like an initial assessment and talk about what's been working in the past with exercise or what women's history of exercise and injury is, and if anything new has come up, particularly during like those hormonal changes and stages of life. But I really enjoy educating women, particularly in the resistance training and strength training space, because it is very, very important, particularly in those later stages. So yes, I mean, every day I'm learning. So I'm 30, so I can't say that I've been through peri or perimenopause, so I'm listening and I'm learning about all the symptoms that are coming up. So there's a big problem-solving component there as well.
Hello. So yeah, as Dom said, I'm a women's health physio with a special interest, I guess, in pelvic health. So we're pretty lucky in that space that we get to see women across the life stages. So from young, adolescent women with heavy, painful periods, not being able to use tampons and wondering why, and then through to prenatally, women that are in their pregnancies, postnatal, and then I guess what is more relevant to today is the perinatal, the perimenopausal, menopausal, postmenopausal client, and a lot of that then is actually looking at the massive pelvic floor effects of menopause and all the hormonal changes, namely the big estrogen drop that comes with menopause, just because it has such a significant effect on women's pelvic health. So yeah, we'll probably go into it in a little bit more detail in the ongoing panel, but that's what I do, and yeah, it's fantastic. I'm sure, like most of us here, we're pretty much, I think, got some of the best jobs in the world in terms of the space we get to work in and the massive positive impact we can have on one's quality of life.
I'm Julia. I'm a GP. You probably all know what a GP does. But so I guess I see my role as just talking to women and listening to their experiences and trying to disentangle what that is, because sometimes perimenopause can also be, what is life stress and what is physical symptoms, and, is it leading towards some other organic illness? Obviously, I can do tests and management and things like that, or referral to these girls.
Okay, so let's start off easy. I'd like to hear some of the biggest misconceptions or that you come across when you're dealing with women in this age group, or even earlier sometimes, around perimenopause and menopause.
Yeah, probably the first thing I always hear is, I'm too young for this.
Yeah.
Pain with sex must be normal, or low libido must be normal. Postmenopause, probably my biggest one.
Cardio is the best exercise for me as a woman.
I think it's just, I'm just tired, or I've just got a lot on. I'll be in perimenopause when I get those hot flushes, those obvious symptoms, or it's just this niggle. I think I've just got a niggle.
Okay, so everyone kind of referenced different symptoms. So we all, probably know by now there's, I don't know, dozens of symptoms that could be perimenopause. How do you, Julia, actually make sense of it when someone comes through the door, given it could be a really different presentation for each patient?
Yeah.
Talk us through that first consultation where you think, I think this might be actually a perimenopause consult.
Yeah, okay. I guess some of the, obviously there's really common symptoms like hot flushes and night sweats and brain fog. There's a really good meme I read recently, I think it was an emergency department one, and it was the 7 dwarfs of menopause, and it was itchy, scratchy, sweaty, sleepy, forgetful, bloated, and psycho. And I thought that was fabulous because it kind of highlights that it's not always just hot flushes and night sweats and brain fog. It might be insane rage out of nowhere, or anxiety, or just that sort of irritability that, can you stop chewing so loudly? That kind of thing. Also, I've noticed some women will find that maybe their ADHD symptoms all of a sudden dial up and get a bit worse when they've been previously well managed. The other things that we sort of see are things like, urinary symptoms, which I guess, Alex, you can talk to that a little bit more. Frequent infections, dryness in the vagina, low libido, that sort of stuff, musculoskeletal pains, aches and pains. But there's also some really unusual things like unexplained tinnitus or palpitations. And there's another really great one I love. I always get it wrong. It's formication with an M, not fornication with an N. And it refers to the sensation of bugs crawling up your skin. Pins and needles, funny tingly feeling. They think they've got MS or something, but they've got formication. So sometimes it's just about listening.
Yeah.
I think my job is just to listen to what they've got with an open mind. Like, why are you here? Like, what's bothering you? And just be curious and let them open that space and talk to me a little bit more about what's going on.
And I'll pass it down the panel. Maybe you might come across women who have come to see you for one particular symptom or issue, and you might be thinking in the back of your head, there's something bigger at play, and what jumps out at you when you're like, actually, I think you probably are in perimenopause, or you should be seeing someone about that discussion? Does that ever happen?
Yeah, absolutely. I think a lot of women, as I said, will come to us with, say, stress incontinence, my leaking with the cough, the sneeze, a laugh. It's got a bit worse recently and in the last few years, and I guess I've, put on a bit of weight, things like that. But you dig deeper into that, and actually the real trigger event for this was it might have been mild. Say the classic is, I think it started after the kids, and it was quite mild, but they hit those hormonal changes, and suddenly, actually, if I put the dots together, it got significantly worse with that hormonal shift that comes with menopause. And, we as physios, and like all of us as health professionals, you don't just focus on just their bladder symptoms. You're asking about their bowels, intercourse, is there dryness at the vagina? What's your libido like? Talk to me a bit more about your gynecological history, your exercise. And inevitably, no one's presenting with just one symptom. Sure enough, they have also got, some issues with bowels, or a little bit of smearing on the undies. I can't wipe clean as well as what I used to. No libido and really dry vagina, and we now barely have sex because of that. And like that kind of thing. So I think, again, there's never really, in my experience, one person that comes in with menopausal symptoms that is just as simple as one organ that's been affected, say the bladder or the bowel. It is so huge, the effect on so many systems, I guess.
Yeah, so to not repeat the sort of pelvic health-related symptoms and cycle changes, I see a lot of musculoskeletal and like shoulder pains and plantar fasciitis, and all of a sudden waking up and cannot get out of bed, so stiff, like creaking, painful body that someone's not experienced before. And in terms of women who have exercised their whole life, all of a sudden they're just not getting, well, not all of a sudden, but they're not getting the same response to that exercise. They might not be recovering as well, so they might be even sorer from a session or a sort of, a gym class that they have done for a long time, so their recovery levels aren't as high. And also just symptoms around, like some GI and bloating, which does affect the session on the day and the exercise that I do with the client and the female. If they're just upset stomach and they're bloating, it makes it hard for them to move freely and feel comfortable in their skin, let alone exert themselves.
I think really, well, as the role of a health coach, we are drawing the wisdom out of the client. So the client comes and you, as I said before, get the messy head out, but then you're also saying you get them to reflect a lot and, how long has this been? What else have you noticed? What do you think? Because we notice that often women they're quite overwhelmed and the confidence has gone low. So again, we're building the confidence up by going, well, what do you know about yourself? Trusting your intuition a little bit there, which I think is really key, and then working out, well, what is it in your power to do? And sometimes there's gaps where they're not sure, and you can say, all right, well, these are some possibilities. Potentially, it might be a referral back to lovely doctors like yourself, or it could be a referral to seeing one of you ladies as well. But that's, for the health coach, it's just helping people sort it out.
So we've kind of experienced the symptoms. Someone's either told us or we've trusted our intuition that I think this is perimenopause. Come to see you, Julia. What's that consult look like? What are you doing? Is there a test that you can...
Great questions. After you've explored why they've come to you, because they've obviously got something that they're worried about, the simple answer is no, there's no test you can do for perimenopause, because when you're going through perimenopause, your hormones are just going on an absolute roller coaster. Your ovaries know what's coming, the end is coming, and they have a massive tantrum, throw all the toys out of the cot, and then settle down again. And then they'll have another meltdown a little bit later. So you just find that, you can't do a blood test because it might be perfect one day, and then 6 weeks later it'll be wrong, so it'll be abnormal. If you actually haven't had a period for over 12 months and you're kind of around 50, then there's some hormones we can check, but in that perimenopausal phase while you're still menstruating, there's not much we can do.
Okay.
So it's all about history.
Symptom-based.
Yeah. And as I said, in my practice I often do tests because I think it's nice for women to know their baseline for some of the things we'll talk about a little bit later about just preparing themselves to be their best form.
And so on that note, if a woman may be approaching perimenopause just because of her age or knows that it's coming, not necessarily feeling symptoms yet, but how would you suggest that they prepare for what is to come?
Well, there's nothing you can do to stop it, firstly. Sorry. But I think I'm a big fan of just basically building resilience.
So if you can get your mental health and your stress reduction as good as you possibly can, make sure I'm sure we'll talk about this, but your diet with enough protein and fibre, exercise, sleep. If you're more resilient, you'll cope with these fluctuations a lot more than if you haven't sort of addressed any of that stuff. So that's what I talk to women a lot about, is just general lifestyle coaching.
Yeah, that's before, you're in full perimenopause and dealing with the symptoms.
Which is when you sleep is harder.
Yeah, exactly. Once we are there and they're our friends, what's at your disposal? How do you approach treatment? I know there's a lot of talk at the moment around MHT, menopause hormone therapy, rebranded, what used to be hormone replacement therapy.
So HRT is now MHT, and essentially what we're doing is we're giving you estrogen to supplement your naturally declining estrogen, and depending on the woman, that's often coupled with progesterone, depending on the situation, and occasionally we'll use testosterone or other things as well. So that's straightforward MHT. I guess when we're talking about using it, it's at the moment the recommendations are only for symptom control, so we'll just do it if you've got symptoms. We know it's useful for your brain and your heart and your bones, but the recommendation is just used for symptom control only.
The discussion around MHT has changed quite a lot over the last decade or so.
Basically, there's only very few people who can't actually use MHT. A lot of that sort of landmark trial with the Women's Health Initiative had a lot of flaws. They also used very old-fashioned HRT, which was pregnant horse's urine, as the fundamental estrogen that they used. So there's a lot of side effects and risks with that. And these days we have so many different formulations that are safer. So most women, even if they've got other risk factors of cardiovascular disease or obesity or something like that, there is a formulation we can use safely. If we use MHT. But there are other options as well. We don't have to use hormones. There's other things we can use as well.
We can just jump straight into that.
Yeah, so I guess, I mean, we've talked about, and we will talk a bit more about sort of lifestyle stuff, but there are drugs that we can, if we're going to go down that sort of drug route, there are, sometimes we use drugs what we call off-label, so they might be actually pain medications or blood pressure tablets, maybe anti-anxiety tablets, but actually work really well with hot flushes. So that's really good for women who don't want hormones or have some reason why they can't. There's also herbal things and a lot of sort of complementary things that we can use, like acupuncture and yoga, St John's wort, black cohosh, red clover. They're all reasonably safe, but you do need to run that past your GP because they can interact with other drugs. But I think this panel that these girls will probably talk about is probably a whole bunch of other stuff we can use. It's not just pharmacological.
Yep. On that note, we might hand over to Alex. A lot of people think physio, musculoskeletal pain, hands on the body. Probably not what you're doing for pelvic floor, or maybe it is.
Yeah, more of an intimate part of the body.
So just run us through the list of symptoms people would see a physio for, or you see value in seeing, and what exactly you do in a consult, and should they be scared?
No, couldn't start that off.
I think she'd be scared of you.
There's nothing scary about this space. So most women, I would say a really textbook menopausal case. I kind of have already gone through a little bit, so sorry if I'm repeating myself, but yeah, they come in, I'm trying to think, one I had today came in, pain with intercourse, but that wasn't her main complaint. It was feeling this heaviness, dragging, bulging at her vagina that she hadn't ever really thought she'd felt before, maybe a little bit after her vaginal delivery 34 years ago, but really hadn't noticed it until recently. And basically go through the history, and sure enough, she's got a background of chronic constipation, has always been constipated, straining down through her pelvic floor, which we know isn't helpful when we're referring to any prolapse. That's probably one of the biggest things that we can reduce to reduce risk of prolapse. But she came in with that, and on further questioning, she has a bit of stress incontinence, so she leaks, coughing, sneezing, laughing, but not that often. Sometimes she leaks on the way to the toilet if she's a bit urgent, but otherwise she most of the time makes it. Had a lot of UTIs in the last 10 years, and funnily enough, menopause correlated around that time. And so, they were really frequent, but they've settled down a bit now. There's, as I said, there's pain with intercourse, but I, have no desire to have intercourse because my libido is, in my boots. I guess they're the like a few classic symptoms. So we've gone through that. We of course ask medical history, medication, surgical history, musculoskeletal history is a big one. And are there any previous injuries, or the classic, the shoulder, frozen shoulder in the last kind of little while, or, this glute tendon that's just not getting better. And of course, then their exercise. And this is where we work really closely with Gem, of course, in terms of what exercise they're doing. But That's like a standard subjective history. And then in terms of an objective assessment, from if we're thinking purely pelvic floor physio, looking firstly at like a vaginal examination, if they're comfortable with that, whether that's an external exam to begin or an internal examination to get an idea of how their muscles are moving, the endurance, the coordination in those muscles, screening for prolapse. So is there, and just for those that might not know what a prolapse is, that is that like heaviness, dragging, bulging in the vagina is quite common symptoms that women report. There are a lot of others though, which I won't go into all of them now, but it is that descent or that dropping of one or more of the pelvic organs. So the bladder, the uterus, and the bowel. You could have one, you could have all of those. And so we assess for that, and we take some measures on the outside of the vagina that help us predict the risk of that prolapse getting worse over time. So that's a little bit about like a vaginal examination. We might use the ultrasound machine to check as well, get a bit of a better understanding of where their organs are sitting relative to the vaginal entrance. And then, of course, we also come back to the outside, screening hips, pelvis, ribs, thorax, things like that. Is there anything else that could be contributing to the load that is on your pelvic floor? You've got these prolapse symptoms and, of course, you're really grippy through your abdominal wall because you do Pilates 5 times a week and you're really grippy here. But I'm really strong. I won't get prolapse if I do Pilates. There's nothing against Pilates, but that classic, I do really regular Pilates, yet I'm just bracing through here and all that load is just going through my pelvic floor because I don't actually know how to get a good functional activation. So that's a basic assessment. Oh, treatment. Sorry, I'm not even there yet. Treatment. Well, oh gosh, where do I start? Pelvic floor exercises. They again.
They're needing it necessarily.
Yeah. I mean, you can release pelvic floor muscles like any other tight muscle in the body, particularly around pain with intercourse or overactive bladder symptoms. Sometimes pelvic floor does benefit from some internal release work. But I guess starting off, if we think about a straightforward stress incontinence or prolapse, let's get them started on some pelvic floor exercises to start with. They're Kegels, but if we can we actually get those more functional and also make sure that we're loading your pelvic floor appropriately. It's not just a few squeezes at the traffic lights. That's not going to change anything, okay? So that's, sorry to break that to everyone, that doesn't work. So that's pelvic floor at its most basic, but I'm sure as we go through, I might be able to talk about some of the other treatment, won't get carried away.
And just as an aside, when I first met Alex, we're at a Physy Bondi cafe and we're talking about pelvic health as you do, and she was recounting to me how she explains why to patients they're having quite painful sex, hand gestures and everything. And few raised eyebrows with, the tables behind us.
Yeah, I can't read it.
But I thought, we're going to get on fine. So that's to say, if you're experiencing any of these symptoms, do not feel ashamed or embarrassed speaking to a pelvic floor therapist. They have seen it all, and nothing will make them squirm, definitely.
The classic,
Drinks on me if you've got a question for her that, makes her feel uncomfortable.
Yeah. And if your GP doesn't mention it, you mention it to them because not everyone's all over it.
Yeah, exactly.
Yeah.
Okay, so thank you, Alex. No, I'm going to throw it back to Julia first. So not everyone has these, really impactful symptoms. So not to scare everybody, if you're not there yet, doesn't necessarily mean you're going to be experiencing all of these symptoms or any. You might be lucky in that case, or if you are experiencing the symptoms but are managing them at home with just non-pharmaceutical interventions, is there still a reason to come see you?
Oh, absolutely. It's just that stage in our life where, irrespective of what type of menopausal symptoms you might be having, the reality is your estrogen is going south. And as a result, increasing risk of insulin resistance and cardiovascular disease, bone density, all those things that, unless you have a conversation with your GP about it, you might not ever get screened for those things. And it's really nice to know that you're on top of all that stuff. So definitely keeping on top of that. Also, just because you're getting irregular bleeding around the perimenopause we don't just assume it's perimenopause. It could be something else. So it is really important that you check in with your GP with that as well.
Get yourself a good GP.
Yeah.
And make sure, if your regular GP that you love, in the case that Kirsty spoke about, just doesn't do this, it's perfectly okay to have two as well, and they can liaise with each other. Okay, let's move on. Exercise. Gem. We know exercise is really important, all stages of life, but what in particular, as women are coming through perimenopause and menopause, do you change what you're looking at considerably? What's your approach there?
So I guess to keep it simple, two main focuses are muscle mass and bone mass. So keeping your skeleton strong and retaining and keeping as much muscle mass as possible as you go through this natural estrogen decline. So I guess when I am dealing with clients, I deal with clients from 16-year-old young girls through till, 60, 70-year-olds. When you're in your 40s or leading into your 40s, it's really important that you are banking as much muscle mass as possible. And I don't mean that in a scary way, like bulking, right? So it's not about that. It's about keeping good quality lean muscle mass just so you can support yourself throughout those later years. And that also goes for your skeletal system. This feeds in really well to strength training, right? So often when I'm talking to women, they're very active and they're busy mothers and busy working and they're big cardio goers. But one thing that they are lacking is a strenuous or a stress on their skeleton and enough to cause enough stress to keep your bones strong. Getting in and assessing people, seeing sort of where the sticky points are. So I'm big on mobility, having a look at how people move biomechanically. And if you've never done exercise before, obviously that's going to look different to someone who's done Pilates and yoga a lot in the past or has a history of gymnastics. So looking at biomechanics, any history of injury and sort of current injuries, pain points, lower back issues is a big thing that comes up, and that's very strongly related to pelvic floor changes. And then from there, I sort of educate around strength training and lifting weights and being safe within a gym. And also, I think there's a big misconception about women getting bulky with strength training, or also later on in life, like in their 50s and 60s, being too fragile to lift heavy weights. So also dealing with people who have osteopenia and osteoporosis, which is a change in bone mineral density. There's often a bit of fear around lifting weights in that time, when that is also a really important time to lift weight. But definitely in the 40s, it's like about banking strong bones and banking strong muscles and lean muscle mass.
I might throw it back to Alex then. So you're going through perimenopause, you might be experiencing stress incontinence or prolapse symptoms. Doctors told you don't lift anything heavy, don't exert yourself. Gemma's telling us lift weights, exert yourself. But from a physio perspective, what do we do?
Yeah, it probably comes up at least every second day. We'll have this classic conundrum where they've been to the GP, GP's referred them to the gynae for their prolapse, and they're, to no fault of the gynae, of course, they're given the handout from the IUGA, which is like a big body that we have for gynecologists, and it says for management of prolapse, along with, not gaining excessive weight, stopping smoking, avoiding chronic coughing is one of the big things. Avoid heavy lifting, try and stop lifting those heavy shopping bags, things like that, which is just impractical, really. And so it's not that advice is wrong. We know that women can unnecessarily put a lot of pressure through their pelvic floor with repetitive lifting. But the thing that we can actually change is we want to get around that in some way, right? Because as Gem has said, there's such a bigger risk to them about like with their bones. And I think the stats, maybe anyone else might be able to remind me, the stat if you fracture a neck or femur fracture over a certain age, I think your mortality shoots up by 3.5 times or something ridiculous. And that's from a fall and a fracture, right? Now, absolutely, it's not a blanket statement to say prolapse won't kill you, but certainly it's not a fracture that leads to then potentially an increased risk of mortality. So my point I'm trying to make is that we need to be able to encourage women to be able to move safely, and if they want to be doing strength training, we need to facilitate that. So what that often looks like is just a few examples is, well, let's assess their pelvic floor. Let's start with that. Let's get good upward support of those pelvic floor muscles supporting the pelvic organs. Let's look at the functional activation of their pelvic floor. So often I'll do a standing assessment, a vaginal exam in standing, which I can appreciate seems a little bit confronting, but idea being, I'm down here doing an assessment, you're up there, there's a pad down just for safety, and I'm, turning my head away. But yeah, assessing their pelvic floor, get them to press a weight overhead while I'm assessing them, or get them to come in at the end. They've been to the gym that morning, they've lifted heavy, they've lifted weights, they come in later that day, and I've looked at their pelvic floor now under fatigue, and I'm reassessing, okay, is the prolapse getting worse? Is anything changing? Then, as I said, looking at their lifting technique, and this is where we work really closely with Gem, is actually how do they lift? What is their strength like? What's their baseline like? Because if this is not a great example, but, if Arnold Schwarzenegger, however you pronounce his name, walks into the room and lifts a couch, that's not a lot for him. For his pelvic floor, that would probably be okay. Whereas, say me, who hasn't done enough strength training, if I did that, I would strain through my pelvic floor. So women that have a great strength baseline, just because they've been diagnosed with prolapse, doesn't mean they're going back to just using a resistance band. Like, their baseline is already so good. We can manage that. And the other thing is then there are pessaries. So I have got my pessary here. Yeah. This little thing. So that's just one pessary. A pessary is a support device that we insert inside the vagina that is basically like a sports bra for your vagina. It holds up and supports the pelvic organs. And so if we know, we've looked on ultrasound and we've looked under load and we're like, actually, yeah, there is quite a bit of descent through your pelvic floor when you lift, or do any kind of jumping strength training, we can insert this pessary. That really provides good support. You wear that under load, yeah, and you can take it out after the gym, put it in a Ziploc bag, put it away till the next gym day. That is an option as well. And then it gives you the peace of mind that you've supported that while they're doing strength training, while we're still working on building strength, building their pelvic floor. And it's not a forever thing, but it's a nice kind of happy medium. So again, as we've said, bit of a disclaimer, obviously, we're not saying that heavy lifting is the first thing you should be doing with prolapse, but the point is everyone's got their individual priorities and background. We need to somehow find a middle ground, and 9.5 times out of 10, the gynae surgeons, the GPs are pretty happy as long as we're managing that risk. And so that's, kind of where we fit into that.
Yeah, and I think that's such an important point. Like, the patient preference and goals also play into the management plan. It's not just a one-stop, everyone should be doing X, Y, and Z. If you want to be doing weightlifting, there's ways around it. So I think that's a really important point. And then one more question for you guys and then we'll move on. But the frozen shoulder, the muscle aches and pains that keep coming up, do you push through it? Do you rest? What's your view on that? I'll start with Alex because you've got the mic, and then we'll move to Gem.
I think, and I'd love to hear Gem's thoughts, but we definitely, we'd probably recommend, see the physio, get it assessed. We don't want you to unnecessarily cause yourself pain, and we want to make sure that if there's anything we can be doing to optimise their movement patterns, things like that. But absolutely, in most cases with physio and musculoskeletal concerns, I can imagine most of you, if you've been to the physio, they're going to give you exercises to do. And it's the same with frozen shoulder. I mean, a lot of the time, and I'm sure, Jem would have a lot more experience with this than me, it is about let's strengthen around it. We don't want you, just immobilised by this, because we know that will make it worse. And so it's the same way, even though you might be perimenopausal and we know that it's, or like potentially this is being kicked off because of your estrogen levels declining and, the calcium chain, like all that kind of stuff. But we still treat it like an injury, and we rehab it accordingly. And again, in our practice, as much as we can, we do then refer to exercise physiologists, so we know that they are rehabbing it appropriately. Sorry.
If you've got anything to add, yep.
Not really. No, pushing through pain, I think it's very individual to the person in front of you, because everyone has a different sort of pain tolerance and pain scale. But no, I wouldn't get you in there pushing through pain if it's uncomfortable. Definitely not. I'm not like that. But I think it's just appropriate rehab protocol and back and forth with the physio and listening to symptoms, and obviously just even things like a pain diary and being aware of how you're responding to your rehab and your training.
Great. Okay, so we've done assessment, medication, exercise, nutrition next. So Shivaun, I'll pass you over the microphone. So obviously nutrition, huge part of health, any stage of life. Once again, similarly, anything in particular women should be looking at as they're approaching this midlife stage? Is protein the silver bullet that social media makes it out to be?
Moment, isn't it? Which, yes, it has its place, and I'll come back to that. But you know what needs to be the cool nutrient? Fibre. Yes. Like, how many women start bloating, getting constipation through their 40s and 50s, and even earlier as well. But when we've got the hormonal changes, we get sluggish gut. And it's interesting. Probably the two things that women in this life stage talk to me about is, Shivaun, I just, gut, I'm bloated, I've got pain, I can't go to the toilet, or then I'm diarrhea, then I'm constipated. And then the other thing they talk about is the increase in visceral fat around the tummy as well. But there's other things too, so I'm going to come back to all that. There's so much. Oh, my goodness. The other thing too is if women have had blood screenings, right, and then suddenly they're like, I haven't changed anything, but my lipids are going up, my cholesterol's gone up, my glucose has gone up a little bit, we've got, increase in insulin resistance. So we look at those biomarkers. And the other thing, which is a bit of a bugbear of mine, and I'm sure it's of you guys as well, that we have bulk billing for bone density scans in our 70s. But if you've had women come in that have actually had one in their 40s and 50s and they've picked this up earlier, then we look at nutrition to support your bones earlier. When we can see the trend going down, we can catch it before women already have osteopenia or osteoporosis. So what else? Also, sometimes iron's a problem if we've got heavy bleeds. So we need to address that as well. And then, yes, protein as well. Obviously, we've got the body composition changes that happen, and we do want to protect bones and whatnot. So we focus on protein too. And evidence base is about optimal is 1.6 grams per kilogram of body weight per day. That's your target. Your minimum for this age is about 1.1, 1.2 grams per kilogram body weight per day. It differs a little bit if we pop in some strength training as well, but that's a little bit of your guideline for how much you need to aim for. I think this is actually a positive thing. We might come back to this in a second, though, about mindset around focusing not on, because women are calorie restrictors.
I did want to ask you, I think especially probably, maybe there's a bit of a generational shift, but the women who are going through perimenopause now or in menopause, have had, I guess, maybe historically a calorie restriction kind of mindset, a cardio queen sort of, approach to exercise. How do you balance that kind of, I guess, innate?
Yeah, exactly. So I've seen a lot of women that come in their diet, what we call diet cyclists. Their whole life they've been on and off diets and, it hasn't worked for them. Or they've been calorie counting or restricting. And the first thing we look at is mindset, because we tend to do this because we think there's something wrong with us and there's something that needs to be fixed. And so when we have that restrictive mindset, it's quite negative. I can't have this. I need to restrict that. I'm only allowed this. If I go above that, I'm failing, or I'm not a good person, or whatnot. So the first thing we do is look at that mindset shift. First thing I say is, wow, you've had a lot of experience. Let's harness some of that experience first. But also we look at, all right, well, what we really want to do now is we want to protect your body. We want to nourish your body. We want to be kind to your body. So what can we do to reframe this around you now eating in a way that is nourishing, that is kind? So that's where we do focus now instead of calorie count. It's so boring anyway. Really is. We focus on, all right, what are these beautiful foods that are going to keep you regular and going to the toilet and having a good poo, like what are they? Like fibre-rich foods, and what are the foods that are, going to help your brain and feel more energetic and better for cognition, so we look at where are your sources of omega-3, where are your leafy greens. We look at, protecting your bones. So where are you getting enough calcium? Are we getting vitamin D from the sunlight? Are we getting it from oily fish? Is it, something that may need supplementing as well? So we look at foods as, things that you're going to enjoy too, because that's the mindset too. We want to enjoy our food. Like, life is short. We don't want to be like, oh, I can't have that little thing because I'm watching my calories. No. We want to be like, I'm really enjoying this lunch, and it's going to be really great for me too. It's going to give me that energy throughout the afternoon. As I said before, it's going to help me regular. It's going to keep my bones strong. Like, having that kind of more positive focus. One of my clients, she said to me, oh, Shivaun, I love this now. She goes, I used to always feel deprived and like I was missing out on things. And she said, now it's just this fun puzzle of how I can get the right nutrients in, but I still really love my food, So she's really enjoying all of her meals now, and she had a complete diet cycle mindset and deprivation mindset, and now it's a positive mindset of what she's doing to be kind to herself, and she's feeling so much more happy and positive because she's working towards this better version of herself, not running away from something.
Yeah. It's and there's so many trends on social media or whatever, and macro tracking is the new calorie counting, and it can get it's boring, like you said, first of all. It really is. So I guess making sure they just know the building blocks to...
Yeah, there's a bit of learning that goes in. Like with this particular client I'm talking about, she's learned about protein and where sources are, and 100 grams of chicken doesn't mean 100 grams of protein, So there's a bit of awareness and learning, but it's in more of a positive way. Yeah.
And I guess during perimenopause, for some people, moods, emotions are so up and down, and that can obviously impact what you're reaching for, and or how you're exercising, I guess, as well. And those good habits might go out the window if you're feeling tired or down. Any tips or tricks?
Oh, totally. Okay, I always say to people, do not judge yourself. And I know that's really hard because, still do it, But when you judge yourself, you feel bad, you want to put your head in the sand, and therefore you think, stuff, it's all too hard. I have a glass of wine and a block of chocolate, So the first thing is just, if you have had the bottle of the wine and the whole packet of Tim Tams times 2 or whatever, you just go, oh, that was interesting. What was going on there? Yeah, I'd had a really shocking day. I was really tired, had a bad sleep. Okay, well, it is what it is. Actually enjoyed the Tim Tams. Some of them I didn't by the time I got to the second packet, but is what it is, So that whole that kindness, the curiosity, the compassion is really, really important. And also, we tend to be perfectionists, a lot of us women, it's got to be perfect. We've got to have and if it's not perfect, then, and you probably get this with exercise all the time, if I haven't done my sessions, throw the baby out with the bathwater. But it's more about just all right, well, what can I do? I'm having a crazy, week. I didn't sleep well. What can I still do so I'm doing something small, even if it's not the ideal? It'd be my biggest advice there, yeah.
Yep. Gem, any in relation to exercise, if they're feeling a bit all over the place?
I think I would just start with breathing, to be honest. I think like throughout this stage in life, what I notice a lot is like women just don't take big breaths, and whether that's because their ribs are so constricted because they've been sucking in for 30 years. No, they breathe with their shoulders, right? So they come in and they go, these don't go down. And I'm like, well, let's just lay on the floor. So I think, if you come in with just like that, you just need to, if you're going into the gym or whatever and you're just not really ready to exercise, and you get on the floor, lay down, and I know, time, you don't all have hours to spare, but just breathe. And I'm not trained in breath work or yoga, but definitely I think grounding yourself, and also when your energy is high, do high energy exercise. When your energy is low, lean into that and do some mobility, do what you need. Don't just, if you're booked in for a HIIT class and you wake up, you might cop a cancellation fee, but it's not the day. Obviously there is an element of discipline and like showing up for yourself, but I think just listening to the signs that your body is telling you,
Can I just add to that? Yeah, on that note, like from the coaching perspective, that's where I'll coach women around doing something small. Like even if they don't feel like doing the HIIT class, well, what is it that you can do? You know what? Okay, I could probably do a gentle walk, out in nature or with my dog, or I could, instead, maybe I could lie on the floor and do some stretching because I'm not getting around to that. And you're still doing something that is positive, but you're listening to your body. And so you're being kind and compassionate and meeting yourself where you need to. Yeah.
I know, Julia, you said something to me which resonated about exercise, and I'm having a bit of a brain fog moment. I can't remember what it was. It resonated that much. But maybe you have something to say on this.
I think I was telling you about how I just see so many women of our age who have not prioritised themselves at all because they've got work or children or something. And it was more of a mantra I tell people that it's not, what was I saying? I think it was, no, it's how am I going to move my body today? No, not what exercise am I going to do, because maybe it's not the day for it, but how am I going to move today? And it might just be parking the car a little bit further away from work that day. Or it might be like, I am ready, put on the music. But it might not be, and it's just about really listening in and showing up for yourself. I think you said that already. And just prioritising yourself. Yeah. Because if we don't prioritise ourselves, nobody else is. Those little toddlers or other colleagues, or, you've got to stand up for yourself.
And pelvic floor exercises count as movement for the day.
Oh, thank you.
Yeah?
But not at the traffic lights.
Not at the traffic lights. But you incorporate some breath work.
You could do it on the floor.
Yeah. That's movement. Yeah.
It all counts. Yeah, I love it. Okay, so we've been talking a lot about the body. I do want to go back to the emotional symptoms, just to touch on, because it is a big thing for a lot of women. The brain fog, the anxiety, low mood, help.
Oh, yeah, some help. And I think probably Shivaun's got heaps to say on this. Apart from having a really good, maybe a really good therapist or a good psychologist or a really good bunch of mates who you can talk to is really helpful. So that the village that we create as women are so powerful and so strong, and I think that's very important. But I've got another thing that I do like doing, and I think I was telling you about this the other day, Dom. I call it scheduling, and it's where you haven't, say you get PMS or something, and you know that tomorrow and the next day are going to be bad days. They're not the days to call your mother-in-law or, to do that thing you don't like. Just do it today or put it off till next week, because you can kind of look at your patterns and it's tracking your cycle and tracking your symptoms so that you can see what's happening. But it's also so you can manage yourself. Do you know what I mean? It's really, I don't know, I made it up, but I think it's really helpful.
And Shivaun, anything?
Now it's my turn to have forgotten the question again. What was it again? We're in a safe space here.
Ways to, I guess, manage the brain fog. We know that brain fog isn't necessarily a sign that dementia's on its way, so take a deep breath and don't freak yourself out about that. But when they're in that kind of mindset that it all just feels a bit hard and hazy, what can we do?
Yeah. Well, as a coach, we talk about holding the space for women when they've, come in like, it's all like, yep, okay. And we just listen. Because the other thing I think with women too is we tend to hold it all together, or hold it all together as best as we can. And we've got so much going on and we manage it, and we're seen as we're resilient and we can do it all and all that sort of stuff. And so I think what happens is we don't catch it early enough, and so it builds and builds, and then we have a meltdown, or we yell at our kid and we don't mean to, or, it explodes. So if we can obviously be more aware and catch it earlier, and like what you said too, schedule or plan things, then that is a helpful strategy. So sometimes what I'll do with women is I'll just say, all right, well, let's just reflect, if they're not in a period where they've had an absolute meltdown, they're going to go, all right, well, what happened last time? What were the triggers that led to that? What could you have done differently? So I think journaling and self-awareness for women is really important to kind of see patterning of when you got to that point where you absolutely imploded. Was there anything that could have been done? And there usually is things that you could have done earlier. Was it that you really needed to sort of put your foot down and say, look, you know what, I've got to go for a walk, or I've got to take some time out, I need a night with the girls, or whatever it might be. What are these things you can put in place that can help to manage the emotions, your state of mind? But as I said, if it gets to that point where again, being kind to yourself, because even us in the industry, right? Like we talk about it, and then we have the moments where we're like, oh, no, I should know better. So we just go, all right, well, got to let it all out, and we get it all out. We feel a bit better after a cry, right? But so as a coach, we sort it all out. We go, all right, what do you need in this moment to help you feel a bit better? Check in with yourself. What's going to help you to take that next step forward? What's going to help you to cope with today? Is there something maybe you need to cancel? Or if you can't cancel it, how are we going to deal with it? So, that step by step, that planning and reducing that overwhelm, taking it back simple, to small steps, yeah.
And then on that note, I guess, all throughout life, but particularly in the midlife, invisible load for women is huge and can feel very heavy if you're managing that and perimenopause or menopausal symptoms. I don't know if this is something you do work with clients on, holding barriers or, putting your own barriers up and, your limits and protecting yourself a bit. If that's not natural to you, how would you suggest, working through that with family, friends, colleagues, and protecting yourself a little bit?
Yeah, exactly. From taking on too much and whatnot, and which is so common. It does come back to our belief systems and our value of ourself and our expectations of ourself and expectations of others. So exploring that is really interesting. Like, what did you notice when you grew up? What was your mum doing? What was your grandmother doing? What do you expect of yourself to show up as a good good mum, a good colleague, a good friend? Like all those expectations we place on ourselves can place a lot of pressure. And often the other people, your friends, are like, we don't need you to do all that to be a good friend. And you're obviously, a lot of it value. And so I think that's something that women need to really question. And then once we sort of work that out and kind of go, okay, right, then it is that strategizing where we go, do I need to have certain conversations with people? Do I need to change my own expectations of what it is to show up as in the workplace, or show up for my kids or whatnot? Has anyone seen, I've just thought of something, Sam Kelly _world? Does anyone follow her on Instagram? No? She has an expression called notice and do. So you're not getting your kids to help out or your husband to help. Like, it's around this whole theme of we're a team and everyone notices and does, you know? So the kids are that message of, well, what did you notice could have been done around the house? Sounds great, doesn't it? Work in progress in my household. I still haven't nailed it. But yeah, I think that whole, that expectation management of others comes in there as well. So at least I've got my daughter. She makes a lunchbox. She makes her own breakfast. She's 8. She makes her own lunchbox, makes her own breakfast, unpacks the dishwasher, makes some of her own dinners. So it's a start, and cleans the bedroom.
I had someone recount to me that, like, I'm going through perimenopause, my hormones are all over the place, and my son is going through puberty and his hormones are all over the place. And it was chaos until eventually I sat him down and was like, you know what you're feeling? I'm also feeling. And then all of a sudden they had this point of, like, mutual understanding, and they just kind of got it when someone was a little bit, off kilter. So, yeah, I guess maybe don't be afraid to share what you're going through. Yeah, exactly.
Absolutely. And that's it. I think we hold a lot in, right? And being able to actually just be open and having those conversations, this is what I'm feeling, and communicating instead of just being the martyrs that happens a lot.
And also, how often have you got a text where someone's cancelled on you and you're like, oh, thank God. So, everyone's going through the same thing, and it's game of chicken to see who fails first sometimes.
Communication, it is key to everything.
Totally. Okay, so we are coming up to time. I have so many questions that I would have loved to ask, but didn't get a chance. So let's wrap up with some quick fire questions. Don't worry, Jules, it's fine. We've gone through, some of these have already been covered, but just to keep it easy, I'm going to flick it down the line. Small rituals or practices that are your go-to tips for your patients that can make a difference in this stage?
I feel like I'm going to steal your thunder. I was going to say move every day.
Yeah, just be aware of your symptoms and don't assume they're normal. Ooh.
Breathe wide in the rib cage, wide.
Yeah.
No, I don't know.
Focus on what you are doing well and what is working instead of what you're not. That's my big tip.
Great. Okay, you can keep the mic for now. So if there's anyone listening who's unsure where to start, they know they have to get something under control. Where do you advise they just make a start?
What do you mean?
With how they're feeling, getting care, anything.
Yeah. Well, I think the first thing is again, trust yourself and don't go, it's just age, it's just an ache. It's that. I think that big thing is, you've all come here tonight. That's fantastic. We're talking, reaching out, connecting with health practitioners in this space. I think that's the biggest thing, is to just don't doubt yourself and don't think, it'll just go away, Take action,
in relation to exercise, I think if you have access to a coach, book in just one session or commit to one session for 4 weeks and just learn and ask lots of questions and bring up all your symptoms, right? Nothing is TMI. Talk about all your pelvic floor symptoms, even your relationship with exercise, your relationship with food in the past, everything like that comes up. So just book in a session if you can. I'm not saying with me, but I'm just saying with someone who is trusted within the industry. And if you don't know any female exercise physiologists or anyone, then you're probably, reach out.
Yeah, similar to what Gem said, I guess nothing is TMI in our field. Actually, the more information, the better. As much as I know it is, a lot of the things that we talk about, particularly in pelvic health, are a bit taboo and, oh gosh, I'd never talk about that. previously with my mum, and that kind of stuff. I think it's so important to share and feel heard. And I feel like half the time, I mean, there's a box of tissues in our room constantly because women are just finally sharing their stories and feel like they've finally been heard because we get to spend so much time with them and really change their quality of life.
And if you don't know what to do, see me.
Yeah, okay. That's short and sweet. I like it, but I don't need that. I'll get you to keep it. Let's finish on a positive note. We've heard a bit about the doom and gloom. It's not all bad. What gives you optimism about what's happening at the moment in, the movement where...
Yeah, well, obviously things like this are happening. The government's pledged over $500 million into women's health. We don't know where that's going to go, but research, subsidising medications and drugs, and that's really exciting. And I just feel like we're not going to go through the menopause that our mothers, sorry, some of the older ladies at the back, but we're not going through what our mothers and our grandmothers went through because we don't have to. We can absolutely dominate.
Yeah, similar. It's such an inspiring space and there's so much happening and it's just talked about now. It's certainly in the zeitgeist at the moment. The Opera House had their menopause event recently and it's so exciting to be a part of it and that we will be the generation that does, like you said, menopause differently.
Yeah, I think it's a really exciting space. Strength training within women and learning to train with your physiology. Bone health is pretty exciting at the moment. Yeah. And the fact that the more you bend and twist and load your bones, the stronger that they get. So that's, throughout all ages. That's exciting.
It's just so exciting now, isn't it, that we're talking about it and that there's all this information and support out there and it wasn't just something that women had to quietly deal with or put up with. So I find that's just suffer in silence. I'm excited for all of us, but I'm also excited for the next generation to come. Yeah, it's we're feeling more empowered, right? We've got choices. We can manage our symptoms. We don't have to just, as you say, suffer in silence, and it's fantastic.
Well, I think that we can round out the questions, but I did want to open the space for the last few minutes in case anyone does have questions they want to ask. No personal medical advice, but if there's any questions, feel free to safe space here. Otherwise, go ahead.
Sorry. Can I just ask, is it too late for someone to undergo hormone replacement therapy if they went through menopause ages ago?
Oh, that's such a good question.
And also, is there a correlation between the lack of estrogen in the body and now more frequent tendon issues, injuries, etc.?
Double barrel.
Yeah, So first question, is it too late to start menopause replacement therapy? So the guidelines generally suggest that you should try and start MHT or menopause hormone replacement therapy within 10 years of your last period. That's the guidelines because theoretically in that 10-year time with those reducing estrogen, you are actually accruing risk factors for cardiovascular disease, so your cholesterol, diabetes, things like that, which might theoretically put you at risk if you were then to start putting an estrogen down the track. But it's always a conversation and it's always an educated conversation. And if somebody realises that they've actually been really suffering, it might be that we do have a informed consent conversation about some of the pros and cons and some of the risks. And I've definitely had some women where I have started it later because all the other risk profile was low and that risk benefit for them, the outcome was so much worth it for them.
So what if I had no symptoms whatsoever?
Yeah.
Remember, not personal medical advice.
Oh, yeah.
So therefore I had no reason to go to the doctor.
Yeah.
Perimenopause or
yeah.
I had nothing, maybe one hot.
It would come down to an individual risk assessment and as I said, the guidelines are generally to keep it within that first 10 years of your last menstrual period. Just for, that's the general advice. General advice. And the second question was about
the estrogen is leading more to
tendinopathies and things like that. Yes, and also wear and tear and I guess poor exercise practices and technique and stuff like that. So I'd probably have to put that over to the girls there, but I'd probably send it to someone like Gemma. Oh. Yeah.
Yeah, there is definitely that strong correlation with lower estrogen and your collagen fibres change structure and your joints become less lubricated, etc. But when you're going through a progressive strength training protocol, the cool thing is joints, if you have joint soreness and you build strong muscles around those joints, those muscles take the load as opposed to the joints, obviously over a progressive and, period of time. But yeah, if you are experiencing joint pain and tendon-related pain, tendons can get stronger and joints can definitely get stronger by the structures around them. And that's even if you are experiencing any sort of joint degeneration, arthritis, etc. That can all, be worked through with progressive strength.
Yeah, sure.
On the flip side, can you start estrogen too early, or could you be too young to start?
No.
So it doesn't matter how much estrogen you have or in your body, you can start whenever.
Yeah, basically on your symptoms. So it's all on symptom management. So if you're 30 and having all kinds of hormonal shifts and signs of estrogen deficiency, it's not too late. It's not too early to start estrogen. And it's also okay to stop and start. So you can give it a go for 3 months. And if you think, oh, God, this is awesome, then we keep going. But if it doesn't really do anything, there's no harm in stopping because we might start it again later. But it depends on where you're at with fertility, contraception, all those sorts of things, because hormone replacement therapy or menopause hormone therapy is a lot lower dose. It's just a tiny little dose just to supplement those declining levels, whereas like contraception is different types of estrogen, but it's to suppress ovulation. It works completely differently, so it's a lot higher dose. So, so to answer your question, no, you could start menopause hormone replacement therapy at any time.
Irrespective if your bloods are saying you're fine.
Yes, because your bloods will always, even in perimenopause, say you're fine. And if you did probably like bloods every second day for 3 months, we'd see the roller coaster. But that doesn't happen. And if you get 2 isolated blood tests 6 weeks apart and they look pretty good, it doesn't tell me anything. So and there's a book. Who is it? Naomi Watts. She's written a book because she went through it 30, 35 or something. So it's the answer to his question is no, it's not ever too early.
And as a follow-on to that question, one that often comes up is there a set amount of time that you can be on it for? So if you're starting it early, does that mean you have to come off it early?
No, so what we would normally do is, if you had to start really, really early, is maybe around sort of the average age of menopause is 51.3. So you might, at 51.3, have a break and just see what's happening, potentially, because you might find that within a couple of weeks of stopping, oh, holy shit, it's all happening again, or you might actually be pretty good. So,
but you can stay on for as long as your symptoms warrant.
Yeah. So, and if you've been unfortunately gone through it a lot earlier, we might have a break. It's good practice just to see if you still need it. There's a lot of research going into the benefits of estrogen for brain health, Alzheimer's, but obviously bone density we know, but that's all research at this point in time, so there's no sort of guidelines for using it for those purposes other than symptom control.
Yeah.
So if you're sort of going through perimenopause and you're kind of all the craziness, is there a point where that all sort of plateaus out and you start to feel a bit normal again?
Everybody's journey is different. So some women will have like a hot flush and that's it, and they're done, and other women will have 15 years of. So it's so independent. So I think when we're talking about tracking before, it's interesting to track and you're, on a calendar or an app or something, just so you kind of know where you're at, because you're going to be different to, to everybody else in this room. So everyone's different. But my sort of take is, if it's starting to really bother you, it's worth talking to someone about it. If it was just a couple of months and it kind of went away for 6 months, maybe you don't need to do anything about it. It might come back, but it might not. So sometimes people just take a while to come around to the idea as well, because they might get some symptoms but they disappear for a bit. Everyone's journey is so different. Yeah.
Do all women experience perimenopause, or can you go fully into menopause, and does it impact the length of time that you experience?
Everyone's different. Some women don't get any symptoms at all, and they just stop bleeding and go off into the sunset.
And those people, it's the follow-on question to what the first person asked. Avoid being on the estrogen gel, or you would still recommend it, like even if they have not had symptoms?
So
So if they haven't had symptoms, would I recommend it? As I said, probably the recommendations at this point in time are you would only give estrogen for symptoms of estrogen deficiency, even though we know it's very useful. That's the general recommendations. But it really depends on what your symptoms are. If it's just anxiety and rage, you may well be better off on an antidepressant. You might be better off just with really good, mindfulness exercises and journaling and a therapist or something like that, and good exercise.
What about no symptoms, but the biomarkers are increasing? So you're getting the increased cholesterol, increased insulin,
Again,
throw a spanner in the works here.
At this point in time, the current research supports only treating symptoms. Because of theoretical risks of using estrogen.
Other things for those.
Yeah.
Do you mind if I jump in as well, just very briefly on topical estrogen? Because, in the physio space, we are often referring back to the GPs religiously asking for topical estrogen, which you would know the stats. It is. It's like this little gem that basically it's applied locally to the vagina mainly, or like a Vagifem pessary. So it's not systemic. I think the amount that's absorbed systemically is a small percent.
Yeah, so even some women who've had breast cancer, and it might be an estrogen-dependent breast cancer, can still use vaginal estrogen. So if you've got itchy, burny, dry, unlubricated, can't have sex, you tear whenever you put, anything, around that area, or UTI, urinary tract infections, prolapse, little bit of stress incontinence, little bit of Vagifem just to plump the tissue up a little bit.
Yeah, it gives it like the suppleness.
Yes.
Yeah.
Yes.
That really good closure pressure.
Yeah, I love it.
Oh, so good. Yeah. Yeah. So a lot of our different demographic, but not to say anyone here is in the different demographic, but our postnatal women will often get them on some topical estrogen while their estrogen is in their boots, and it just has a massive effect on stress incontinence and things like that, because we need estrogen for good tissue quality for the same other reasons we've discussed. And a lot of women, when we're talking about, which is not a physio conversation, but you ask them if they've been on MHT or things like that, are still particularly of that different generation of the belief that absolutely not, but you can get them across the line a lot of the time on some topical because their main symptoms are the genitourinary symptoms of menopause, which are the UTIs, that pain with intercourse, stress incontinence. Yeah. And it's so local that it just makes such a big difference.
Yeah, it's amazing. Yeah.
And I think an important point on that, back to do your symptoms reside over time? Hot flushes of the systemic symptoms generally, who knows how long, but will get better.
Most people, they will subside within the first I think they say 2 to 5 years.
But that's not the case for the dry vagina.
No.
So that can be lifelong. So get on the Vagifem.
Word I hate called vaginal atrophy.
Vulval atrophy.
And vulval atrophy, which just sounds like a shriveled up prune.
Yeah, or gaping.
As I said, no need to feel embarrassed about anything with these guys.
So your symptoms, the hot flushes and the rage and, all of that, so brain fog and stuff may well settle, but the vaginal symptoms often, will continue.
Yeah. You mentioned that there are some reasons that people can't have MHT.
Yes.
So apart from, you mentioned breast cancer before, what would be...
That's the only reason somebody cannot have MHT apart from vaginal estrogen, and it depends on the type of breast cancer that they have, because they might still be allowed to use the vaginal stuff. Other conditions might dictate what formulation we use. So, for example, if you've got migraines with aura, or you've ever had a blood clot like a DVT or a pulmonary embolus, so a blood clot in the lungs, where traditionally we'd avoid the pill, or if you had really high blood pressure or something like that, we could use a gel or a patch because you don't get that metabolism through the liver and have that sort of systemic effect. So the only people who can't have MHT, either is someone who's actually had an active estrogen receptor positive breast cancer. So that actually opens up a lot of the population to be able to use MHT. But again, it all has to be tailored to your personal risk factors and preferences and,
Anything else? Yeah.
Someone on the panel
mentioned about the fact that bone density scans are only offered at like 60 and 70.
70 years old is the rebate.
Yeah.
Through Medicare.
Through Medicare, yeah. So what age should we be kind of going and getting that for ourselves then to kind of understand where we're
I think in the 40s. I mean, okay.
I often, if I'm having a conversation with someone about perimenopause or menopause, I'll bring it up. I'm like, you've got so much time to build up your bones, and if we find out they're a little bit weak, off we go to the gym. Let's get our diet really good. Let's make sure, because some people don't absorb vitamin D through their skin very well, or they don't eat it or they don't absorb from their gut. So there's so much we can do if we get in early. There are some caveats to that rebate where you can actually get one earlier, but they're only about $100.
They're not
So it's
expensive.
not that bad. You do it
earlier to know where you stand.
Yeah.
Take some action.
Yeah.
You can also get the body composition and you can get the bone density done. And you can see the visceral fat, which I know it's not that pleasant to see over time, but it still gives you an indication of what's happening from a body composition point of view over time as well.
Yeah, and you wouldn't need to do a bone scan every year. You might do it somewhere between 40 and 50 as an opportunistic moment and see where you're at. And if they're really good, keep doing what you're doing. But if it's not good, we'd intervene and then check again. Yeah.
Yep.
And I would particularly recommend if you've had, and I'm not saying you have it all, but people who haven't grown up with an active lifestyle, so you might not have played sport as a child, particularly getting a bone scan earlier, because you build your strongest bones earlier on in life. So if you go the first 2 decades of your life not really doing too much, then the earlier the better with that bone mineral density.
I'll add to that too, and I hate to bring this up too, but disordered eating and diet cycling can also play a role in that too. So earlier the better for that too.
I was just a quick follow-up. Just is that like hereditary as well, and kind of if you have a mother that has had
definitely. So osteopenia and osteoporosis are there's a strong genetic component there. It just depends sort of what your environment is, and as I said, like if your mother had it but you had a very active lifestyle and very different lifestyle to her, then you're at lesser risk. But no, there is definitely, if you have a more frail mother and grandmother, that's more of a reason to get in there and get it checked.
And just quickly, there's a few other conditions that might make it worthwhile doing a bone scan earlier. If you'd had a chronic inflammatory disease or like gut disease, so celiac disease, if you've ever been on high-dose steroids for some sort of joint problem for a long time, rheumatoid arthritis, like lots of autoimmune conditions, you can actually get a bone scan earlier because they put you at much higher risk. Or if you had a period of having no periods for a long period of time because of disordered eating, athlete, I don't know what happened, something else. Lots of things can happen.
Yep. Anything else? Otherwise we can wrap.
So everyone last
Yeah, go for it.
Are you supposed to take HRT in order to help prevent or to help symptoms as you're facing them?
Yeah.
Or are you supposed to be taking estrogen as a preventative measure for lifestyle diseases?
Oh, it's so good question. So I would like to agree with the second half of your question, but to be really boring and GP-ish, but the guidelines suggest at this point in time, the recommendation is to only use it for symptom management.
And then you stop after your symptoms?
That's what they say now. But that's where we're hoping this research is going to be coming through, saying it's safe, let's use it for other things. But at the moment, we're only using it for symptom control. If that makes sense.
But there's a lot going on about whether you do it for preventative.
There's a lot of research going into it, and there's lots of stuff coming out how beneficial it is to every part of our body. But at this point in time, they can't make the recommendations. So Daisy, did you?
It's probably a silly question, but
Never.
If you're taking HRT, do all of your symptoms go, or there's some that just can't be fixed?
Oh, again, everyone's different, and sometimes it needs tweaking because there's not one size fits all for everybody. So some people end up on like a patch and a tablet and a bit of gel, and it depends on what's going on for you. Yeah. Sometimes it's not a silver bullet. It's not always perfect. Some people do get complete resolution of everything. Others will just get pretty good over here and a bit of that, and that one, nothing. So, yeah.
Sorry, I have a follow-up question to that. Testosterone. I sort of a couple of friends are like, I'm trying this and I've been tried on this and they've upped this and they've down that. Thrown in a testosterone measure. So talk a little about estrogen.
And progesterone, yeah. So testosterone is very controversial. At the time of speaking, the only indication for using testosterone in women is for hypoactive sexual arousal disorder. If you look at the criteria for that, it's like not wanting to have had sex and it causes you distress for 6 months or something. There's some really stupid like time frame and collection of symptoms, which I don't know. As a GP, yeah, low libido. Like, so that generally what most doctors who prescribe menopause replacement therapy and things like that would usually start with estrogen and progesterone first. See how you go. If you need something else, we'll play with the testosterone as well. Yeah. But again, it's a one-on-one, it's an individual consultation. So there might be reasons why we might start you on Androfem as a cream or Testogel or something first. Yeah.
And this, I think, goes back to maybe you mentioned this off-label use. So in Australia, testosterone is approved for use in
hypoactive sexual arousal disorder,
but it's within any doctor's remit to have a individual conversation about the risks of using it and the evidence for using it outside of that indication. And if you're both in agreement that it might be beneficial, you can try it.
Yeah, and you can give it a go for a few months. And again, if you don't like it, you can stop it. So, and testosterone levels we can actually check with bloods to make sure we're not having too much or too little. Estrogen and progesterone, we don't check them. But again, it's about having a really good conversation with a GP who knows about this sort of stuff. But it's very controversial still, which is why it's not widely offered. Hopefully the $500 million will go somewhere to do with testosterone. Yeah.
And there are some big testosterone trials that are ending, I think, at the end of this year. So we'll have more evidence either way on whether it's beneficial for other things other than low libido, I'm going to call it. Yeah. Yeah. Okay.